Welcome to the Docs Who Lift podcast, where we distill and simplify the complexities of a healthy lifestyle, exercise, medicine, and weight loss. We're excited to bring you a podcast that's a prescription for clinical practice, scientific recommendations, and just real life. This is the Docs Who Lift podcast.
Hey, and welcome back to the Docs Who Lift podcast. I'm your host, Dr. Spencer Nadolsky, co-host Dr. Karl Nadolsky here. And apparently the microphone was a little bit too close to my face. We can never get the microphones right. Apparently people could hear me breathing. So
yeah,
panting
it's not appropriate.
Well,
are you sure? And you're sure it wasn't my microphone? Because I'm trying to hold it up to because people said that mine wasn't loud enough before.
That's what I asked people, and they said no, it's for sure you. Okay. All right. This episode,
you also have some problems, but yeah.
We're going to be talking about what we believe is the right way to practice medicine, like including the whole system of medicine, and why we're transitioning from our current job or our past. Well, I've already left Weight Watchers.
We're in the. We'll talk about it. We'll do some updates as to what's going on. We've alluded to it right in our previous podcasts. Social media is certainly given some updates now, but let's just talk it out a little bit, and it'll be a short and sweet.
Yeah. So the gist is, a lot of people think I was the owner of Sequence. I was the first doctor. I had a significant, for an technically employee, a significant amount of equity. But I essentially took it from zero to, I don't know what it was when we got acquired, something around 20 to 25,000 patients within like a year or so. In fact, Weight Watchers wanted me to be on their scientific board of advisors. And at the end of the call, I'm like, this whole time I thought you were going to buy it. In fact, my brother remembers when I kept saying, I'm like, Weight Watchers wants to get on the call with me. I'm pretty sure they want to buy Sequence.
Yeah.
And no, that's not what they wanted. They wanted me to be on their scientific advisory board. And then I was like, hey, don't you guys know about Sequence? And then within like 2 months, it was bought. So I kind of got adopted by them. I never just thought about working for Weight Watchers. So it was just kind of interesting. I was
why would anybody?
Now I'm the, what's that?
I said, why would anybody think about that?
No, I don't know. Because I'm into nutrition and whatever, but they weren't a healthcare company. So I was like, all right. So I kind of got adopted as their medical director. And so it was cool. It was fine. It was just a different kind of experience in a public company. But the way that I want to practice medicine it's just a little bit different. I want to go a little bit deeper into like that cardiometabolic care. So I think about this before because I think the access is important. So because what you'll see that like a lot of the people that came to us at Sequence, they're not only just their primary cares, they're endocrinologists. People who just refused to give them the help that they need. So like, it's a double-edged sword. When you increase access, there are some people that may get through. I mean, the thing is, I was the one. So
then this goes back to why our system sucks.
So this is what I wanted. Here's what I want to do. I would like to go deeper in the care. I think a hybrid approach is best. I think virtual can scale as a business very well. And I put my wait list out there and, there's already thousands of people. I'm going to be filled up as a doctor very quickly because then what happens, and I did this at 2 startups. I worked at SteadyMD. I was their first doctor, got them 400 patients just for myself. And then all of a sudden the next doctors came. It wasn't as nearly as cool as what Sequence did because people didn't care about primary care. They cared about weight loss. So in terms of weight loss, people wanted to sign up. That's why we got 25,000 people within a year. So what I want to go I want to go deeper. I want to do more of that lipid management. And what's funny is, so when I'm asking these potential patients what they want, they're not all saying GLP-1. A lot of them are saying, I need lipid help. I need cardiovascular prevention, metabolic health help. I want body composition help. I'm already on a GLP-1. I want to come off, or I want to do maintenance. So a lot of these people, it's a lot of people with familial hypercholesterolemia. I'm a lipidologist. They want help there that they're not getting as much, whoever they're seeing. So, but I think a hybrid approach, if you can muster it, and
When
I've
you
talked
say
with them.
hybrid, tell people what you mean.
Yeah, hybrid. So a hybrid approach would mean a brick and mortar plus virtual.
Right,
The
which is
thing is,
actually what most healthcare systems tried to do
they should,
because it
but
thinks the silver lining of the pandemic. It's something that's been discussed in healthcare for a long time. I mean, when I was in endocrine fellowship, we talked about how people with diabetes and exactly what you're talking about, obesity, diabetes, cardiometabolic optimization, all these sorts of things that we do can be done very well and efficiently through virtual medicine, remote monitoring, quickly touching base about, glycemic measures, lipids, all the things, right? But it wasn't until the pandemic hit where suddenly, and this gets talk about system dysfunction, because it's all about what insurance is going to cover, Medicare, big insurance, all these different things. And so then that really kind of opened up the door, and you were all over that, leading the way.
yeah, the issue is, though, insurances are starting to want to only pay for in person now. And here's the deal. Here's what I believe. I don't think it's actually possible to deliver a very high level of service without taking a membership fee. I think ideal situation, insurance would pay for it, but in this fee for service world, fee for service means the doctor only gets paid when they see that person, or have some sort of interaction. But if you take away that, this is the whole direct primary care or direct care model, where you make a membership fee, then forget the insurance. Then let's just do the transaction between the patient and the doctor and just pay for the services straight up. Now, I think ideally in the future, I would move away from membership only, subsidize the membership with insurance. It's just easier said than done. So that's what I think. I think a hybrid approach. Most people will do the virtual thing and then be seen in person once in a while.
Yeah. So we do that a lot, and we've been doing that especially ever since all the insurances allowed us to do it. So we've been doing that for, I guess, 5 years now, right? Well, almost 5 years.
Yeah.
We do a ton of virtual.
So yeah, that's what I'm doing. I'll share with the name and the brand in a future episode. There's some things I'm working out, but that's what I'm doing. I'm moving towards that. I got a lot of doctors that want to work for me, and I think
you're also very humble about it.
Yeah, well, proof's in the pudding.
Well,
You know what I mean?
Oh, here we go. Well, so on the other hand, you call me the martyr because I still feel like you talk about access. I still am very concerned that most of the people, the types of patients who really need the most care, the most intensive therapy, the highest risk people, type 2 diabetes, cardiovascular disease, kidney disease, the high level lipid stuff, and then all the other endocrine things that I see, I just don't, I'm not sure at what point people would want to pay some sort of membership to allow the visits to be longer and more accessible and all that stuff versus straight insurance. So again, kind of coming up with some sort of hybrid or multiple programs is something that we're talking about. So I guess I should give a little background for us. So my team and I left our big, huge West Michigan medical conglomerate endocrinology department a couple of years ago to start the department at our local Holland Hospital healthcare system. Basically, that's one of the last standing independent healthcare systems in the state of Michigan. And it was very exciting. That's where we were both born. And so I was very proud of that. Well, then kind of out of nowhere, a month ago, they told us that in March, they are shutting us down. Now, I can't really say much more beyond that, not because I'm not allowed to, but because they're not allowed to tell us what's really going on. We think there's some financial things, which goes back to what we're talking about. We have to somehow be financially viable, but balance the care we provide. And we provide, I think, very good care. We spend a lot of time with patients, which goes back to how that doesn't reimburse the healthcare system that well, because the stupid fee for service, you got to see more and more and more patients just to get reimbursed. But the insurance companies, they're trying to go to more quality measures and pay for better quality care. It just doesn't work well yet. And they haven't figured it out. And so anyway, so my team and I are going to start our specialty department literally moving into a gym. So we've talked about the gym clinic, basically all of our medical careers, how that's our dream, and building a gym in our clinic has proven somewhat difficult. So we're just gonna, if we can't beat them, we'll join them. So we're gonna literally move into one of the awesome gyms in town, use their space, see what kind of partnership we can develop in the future. But we're going to do our endocrinology, diabetes, obesity management, and all the other things, and see what kind of programs we can come up with without the thumb of a big healthcare system pushing down on us, and do things our way. But unfortunately, now I have to learn to not necessarily be a complete martyr, as you call me, and actually learn some of the business stuff so that we can be viable. But it's not like we have to, I don't know. So we'll find out. We're talking about some programs that would be similar to like what you've done, but also trying to really optimize the patient's insurance, get the most bang for the buck for them and for us, utilize my dietitians very well, utilize the remote monitoring, all the virtual stuff, and make sure we can get the most value for what patients have to pay and what their insurances are going to be able to pay. And then maybe we can expand too, so we can have endocrinology at the gym, and that's basically where we are with that. So starting in March 2025, for anybody in West Michigan, we will be doing hormones, diabetes, weight loss therapy, intensive programs, diet, exercise at MVP on South Waverly in Holland, Michigan.
The hand sanitizers will have androgel in them.
God.
So essentially what happened, my brother joins Holland Hospital. They go broke because of
Yeah.
No, but you can imagine though, you're trying to spend more time, like you're trying to do
things right, and
but they're not getting. This is why I think that and again, I'm not saying there are people out there. We know doctors that obviously there's the Peter Attias out there that charge apparently a couple $100,000,
and they don't even have a specialty, and they're just they pepper in a bunch of misinformation with real stuff, and that people believe they're BS.
That's the extreme. So most people don't do that. There are other concierge doctors that's like $3,500, $4,000 to see them for an initial visit. Follow-ups are like $1,500 or $1,200 or something like that. So if you can imagine, we're not talking about that. I'm talking about like, okay, how much is a Netflix subscription? How much are things that people are used to paying? Like, I think people should invest in their health instead of investing into whatever Netflix
they should.
And others.
The problem is the way our healthcare system has set this whole thing up. It is, I mean, and people are getting screwed by their insurance companies.
Yeah. No,
we're not going to get sponsored by any insurance companies. I can tell you that for free. I feel like they, along with the whole PBM middlemen, everyone's jacking up the prices for patients for, paying doctors less even, and the healthcare system's less. The whole system's wrong.
But so this is why, you're saying how you didn't like the sequence model and the other models, but like the thing is, people go to those because they can't even get access they can't even get into their primary care. And then the problem is, I'm
fairly confident 90% of our patients would not add any extra payment. And maybe it's just where we live. But
then the primary care doctors are stigmatizing. They tell them they need to. So this is what the reason sequence was so successful is, again, here's my prediction. I think what's going to happen, and this is why I'm doing what I'm doing, I think there's going to be a lot of these places. We are one of the first ones to do this, but there's so many places popping up. Most people are going to be like, why am I paying a subscription fee to have access to this medicine? I can go to my primary care.
Mm-hmm.
Well, you'd pay if there's quicker and better responses, deeper care, and whatever. But I think at some point, people are going to start going to the PCP. So if you can deliver more value, and I'm not, again, the way I'm thinking is more like $150 membership fee. That could go down
per
to
month, though. You're saying,
yeah.
Right?
So that goes down to like maybe 50 or 70 once you can start figuring out the insurance piece. That way it subsidizes it. But I do think if you, like, I'm looking for a concierge doctor in this area. There's not even a concierge doctor in this area. I want a concierge.
Why do you want a concierge doctor?
Because I want to be able to take if my kids. You can't even get into these people. You can't even get in.
We don't do that. We're fine. We always get in when we need to get in.
No, not around here.
You're spoiled.
No, you can't even get the care you need.
Oh
Takes
God.
weeks, months
Oh jeez.
to be seen. So,
Oh.
but there are people, they want to invest.
But then we won't have enough doctors to do concierge because
No,
already doctors are overworked and
no.
underpaid.
So here's what
So
happens.
that's the problem.
Here's the concept. Doctors are quitting because they can't stand the
Well, yeah,
current
that
system.
too.
So then you
Yeah.
get more and more doctors actually interested in this because they feel like incentivized, and not only just monetarily, they'll actually feel like they're practicing medicine.
But if they're not seeing enough,
You have
that's the
more
thing,
doctors doing it then.
You think,
You have
you
more
think we'll have more doctors
I
somehow.
think so. I think we're going to keep the way the system is now. More and more people are going to quit, and that's why we're seeing people going into the concierge route. And even still with my model, like I'll probably end up having 400 or 500 patients under that model. Not like a usual primary care of 2,000 or 2,500, but then you get more medical students interested in this model. I think we're going to see it, but
well,
I don't know.
then the other problem, of course, that we haven't touched on that we've debated a lot is like how really to do that in a specialty consultative model. So in my specialty, we have some patients who they get a referral for something where we do evaluation, we get them figured out, we treat them, or we sometimes we have to get them to a surgeon for, like, let's say parathyroid disease or whatever, and then they're done, right? We also obviously want to support our primary care colleagues for a lot of the chronic diseases that we're the specialists in, the high level obesity, diabetes, heart disease, kidney disease stuff, and and also kind of reduce the burden of just seeing doctors on them. You know what I mean? We want to have a spectrum of, intensity and frequency of seeing patients and treating them, but also some people just don't need that. So in that sort of model, we got to figure that out. You know what I mean? Because there are people who they get consulted, they come see me, we figure it out, boom, they're done. You know what I say? And I always tell them, hey, our goal is really for you to not need me. I'm going to try to be around. So then there's that whole other concept too that we'll have to. And I know there are endocrinologists out there who have pretty big, decent initial consult fees, but for that reason, because then bing, bang, boom, they figured out it's all kind of included in that. Maybe they get some insurance reimbursement. We're talking about maybe doing these super bill things where, patients have to pay up front, but then they get reimbursed by their insurance company.
Yeah, that's what a lot
all
of
that
people
stuff.
do.
So anyways, we'll figure it out. We got to find a way for people. I promised everyone will, remain in town and accessible one way or the other, but we want to have longer time and stuff with patients too. And so we got to find a way.
Yeah,
So we'll have to compromise a little bit, maybe.
So yeah, I think the innovation. So like what I want to create next, obviously I can't call it sequence, but a sequence 2.0, the evolution of it is, I think, going from access. And again, I was the medical director. I created the protocols. I made it safe. I think it was better. It is better than a lot of primary care doctors out there. But I think the next evolution of it is that it's got to go more than just safely monitoring just GLP-1 medicines. It's got to go beyond access. It's got to go into deeper health.
Yeah, you got to personalize therapy for people. You can't just have. I mean, this goes back to what I didn't like about and it's not just Weight Watchers, it's all of them out there. People are just paying, and if they have insurance, then they give them these really expensive medications that they may or may not really need. So there are people who have the most indication for them clinically, and we know this. I know you know this.
But again,
the people who have heart disease, diabetes, but it's but then we're all going broke. So now the insurance companies are going to stop paying for those when we should have access for those who really need it, because a lot of doctors are like, fine, and the patients are like, well, I want it, so then fine, your insurance covers it, great. And then the people who really, really, really need it have insurances that don't cover it at all.
That's a system issue. That's not the doctor or the program issue. Because honestly, there are going to be dermatologists, anesthesiologists, people that shouldn't be prescribing these medicines, prescribing them, that we're seeing right now. So I would say, it's kind of like harm reduction. I think, hey, these people are going to try to get it. Well, let's do it, and do it at the safest way possible. Now, if everybody were a good steward of medicine and everybody's connected to the insurance, and
that's what we need people to do.
Yeah, but
people need to do what's right.
There's not an incentive. There's no incentive to do it like that.
I know that's goes back to, and then they get a bunch of quacks, by the way, in Congress, right? It wasn't like RFK and
it was terrible. Ron Johnson's thing. It was terrible.
It's like, oh my God! So you have these quacks now talking to Congress about healthcare?
Yeah, it was.
Jillian Michaels was there. our friend
terrible.
that she won't publish our podcast yet.
Better publish it, Jillian.
But it's like, well, why don't you get some physicians in here and talk about the politicians? They argue about the wrong stuff in medicine. It drives me insane. Our system is so dysfunctional, and they never, they just have the kind of the Medicare for all versus the whatever the heck the other side argues. And it's like, you guys aren't even addressing the problems we have.
No, I know. Because they
God.
rightfully so want to improve the food environment, which I think is fine, but none of
that's
them
that's a much bigger
but
issue.
none of them even know they want to remove like seed oils and stuff like that. It's like, okay, that's the stupidest thing. Like, sure, let's go after some of these foods that are easily overeaten, whatever. Anyway, when they make it a false dichotomy of course, drugs versus food, it's like, no, we can all do
everything, and exercise and everything. So
anyway, that's an update on what we're doing. Stay tuned. Obviously, my brother will be doing his thing. I want to open a brick and mortar clinic,
but you declined my offer to have a gym clinic. Like
I'm not
dream
going
forever. Nope,
I'm an hour and 15. My brother wants me to drive an hour and 15 minutes.
We could have made one at your place.
He actually left a job prior because he had to drive 20 minutes. So he wants me to drive.
True.
He had to drive 10 minutes, and he left. And now he wants me to drive an hour.
We could have built one there. That's fine. Whatever.
Hour 15 minutes. God.
All right.
Anyway. All right. So shoot us an email if you're interested in joining our practices and all that stuff.
We'll do an update, a part 2 of this once we get a little bit closer to those things happening.
Yeah, coming out soon. All right, here's our outro.
Godspeed.
If the outro will play.
This podcast is for entertainment and education and information purposes only. Remember, the physicians on this podcast are not your physician. It should not be considered professional or personalized medical advice. It should not be used to replace speaking with your physician or medical professional to discuss your specific health concerns. The topics discussed should not be used solely to diagnose or treat any condition. As a result, we are not responsible for any unwanted medical outcomes. The views and opinions discussed are of those of the host only and do not represent those of any other entities.